Good evening, everybody. My name is Christopher White. I'm one of the clinical social workers here with the Dementia Care Collaborative, and I am delighted to introduce our speaker tonight. Dr. Matthew Russel is the clinical director of geriatric medicine and the medical director of the Ambulatory Geriatric Medicine Initiatives. Dr. Russell is board certified in internal medicine, geriatric medicine, and hospice and palliative medicine, and has practiced across the spectrum of healthcare delivery in both fields. And this is also including home and off-base practices and skilled nursing facility and acute hospital care. And with that, I turn it over to Matt. Welcome, Matt.
Thank you so much. And thank you, everyone. It is definitely a night to be inside watching a screen and not outside being out on the porch. So with that, I'm going to share my screen and hopefully it will look correct. Judy, if you just want to let me know, is it looking right? Okay, good. I got a thumbs up. So what I'm hoping to talk to today is really what happens after the specter of dementia has been raised. Where do we go from here? And I'm sure many of us on this call can vividly remember when we heard that word and the panic that ensued around this. And so we're hopefully going to unpack some of that and talk a little bit about how we approach patients on an individual basis. So I'd like to start with the story of a patient. So Sandy is a 74-year-old retired school administrator who has been noticing that she is more forgetful of late. She lives alone since her husband passed away a few years ago. She's still driving, but has stopped going onto the highway and really doesn't drive at night. She tries to avoid unknown driving routes. At church, she's having a hard time remembering the names of the other churchgoers and feels self-conscious. Her daughters have noticed that she is not cooking like she used to. She was a fantastic cook and entertained all the family holidays. Sandy tells me that she can't be bothered to cook a big meal for one, and microwave and takeout is easier. She goes on to say that one time she left the gas stove burner on, and that made her concerned that she was developing memory problems. So that's just one person's story. It won't be many persons, just one more. This is Dave. Dave is a 76-year-old retired bus driver, and we are seeing him for an annual checkup. He lives at home with his wife, Nancy, and their two dogs. Dave feels that he's doing well physically and tells me that he's exercising several times a week and keeping himself busy with his hobbies, including a record collection and bowling. As he's saying all of this, Nancy is rolling her eyes as she makes eye contact with me. She takes me aside while he's getting his routine blood work and tells me that Dave has not been part of his bowling team for over a year. He hasn't really left the house for several months since their kids took his car keys away. Dave has had several episodes of getting lost, and the last straw was having the state police call her when he was found at the state border. He's more forgetful and gets angry at her when he misplaces things in another room. So these are all very kind of a common signs that something might be going on with the person's cognition. So the signs that something is not quite right. Sometimes people will have awareness into it, as Sandy did, and other times people absolutely will not. And that's one of the things that's really important to understand about dementia, is that it doesn't affect all people in each brain the same way. What dementia is a dysfunction of two or more cognitive domains that causes an impact in a person's ability to live independently. And we'll talk a little bit more about that. So the common signs we'll encounter are memory loss, which is typically noticed by someone else. But as you can see with Sandy, oh, I'm just kind of forgetting names and I left the pot on the burner. So she's noticing that there's some memory, but for the most part, people will say it about their loved one rather than the loved one saying about themselves. Difficulty communicating or finding words. People will sometimes say, this is a spoon. Give me the pencil. and they'll be pointing at it, and they'll have a hard time finding the word for spoon. Difficulty navigating tasks, visual spatial abilities. So sometimes getting lost while driving, but sometimes it can be having trouble cooking a recipe that should be very familiar to the person. Difficulty reasoning or problem solving. When the thinking part of the brain that solves problems, that anticipates, that is able to sort of self-soothe becomes impaired, you can see people becoming very frustrated very easily over things that really aren't that big a deal. Hence the difficulty handling complex tasks and trouble planning. So how do we diagnose it? Well, it really requires history. We have to know what is the story. And many physicians will tell you that a patient in an exam room is not even half the story, because many patients don't report their cognitive symptoms because they may not be aware of them, or they want to minimize it for fear that this may lead to some loss of control on their part. So we will do, as geriatricians, we will do a good history, taking the story from the patient and the people around the patient. What's been going on? What are the concerns? Listening for things like family history. Some kinds of dementia are associated with a family history. Many are not. Most are not. In the exam room, when we have a cognitive concern, we will put a patient through sometimes a mini screening, and then sometimes a longer screening test of the different cognitive domains. There may also be a need to draw some blood work to rule out problems with hormones and problems with nutritional deficiencies. And lastly, we'll look at the brain. We'll look at it either with a CAT scan or an MRI. What are we looking for? We're looking for signs of atrophy, or potentially too much fluid on the brain, or sometimes if people are having an acute change in their mental status, that may be the sign that they've actually got something like a tumor in their brain. And that's something we look for. For the most part, in our patients for whom we have concern about dementia, we're not worried about a tumor, but it is part of the whole workup. Who diagnoses dementia? Primary care doctors can certainly detect it, but generally speaking, we refer to specialists, geriatricians, neurologists, neuropsychologists, and geriatric psychiatrists. Some advanced testing can help us look to see what particular kind of dementia a patient may have. In some dementias, it really matters that we know what it is, because certain medications can be not helpful if we're not careful. There are many kinds of dementia, and they each have many different trajectories. So a person can have more rapid decline, say, in language skills, but preserve some of their ambulatory skills and visual spatial. Sometimes people will have a loss of their reasoning area much more rapidly than something like their visual spatial or their recall. And the point is not to get you to memorize this, but to really focus on what we're really going to be talking about, which is the individual person, knowing what that individual person's trajectory and story has been. Where are the challenges, and where are the preserved skills? So obtaining a diagnosis isn't like that. There isn't a blood test at present that tells us, oh, you have this kind of dementia. It requires observation over time, because many patients with dementia will present with what's called mild cognitive impairment, meaning the very early stages. And that may progress to dementia over time, but again, it has to be observed. And it really relies on the feedback from both the patient and the people around the patient. So again, receiving the diagnosis, it just brings up a whole slew of things all at once. And I did this word cloud to kind of say, you know, do they need a nursing home, wandering, memory, behaviors? This is grieving something. all the medications, what's going to happen with the finances and the driving? Are they going to know what's going on? Is someone going to exploit them? There are innumerable concerns. But it's not an overnight process. You have time. And planning takes time. And dementia is progressive, so we need to take time to plan. Many times, patients and even some caregivers would rather not know that dementia is a diagnosis. The patient may feel that, what's the point? There's no point in diagnosing a disease for which there's no cure at present. Additionally, family members may subconsciously associate abnormal lapses in memory and behavior with normal aging rather than acknowledging that a problem exists. The main thrusts of our recommendations are to ensure that the person with dementia is safe and well cared for, and that the caregivers are appropriately equipped with knowledge and resources. So knowing what's ahead allows for planning. What's important to me to do while I'm able? Remember, dementia isn't an on-off switch. Getting that diagnosis doesn't put you in a nursing home. It gives you a chance to say, okay, this may progress and I want to do X, Y, or Z. What is important to me that I want to make sure others know about so that they can speak on my behalf? I want to make sure we spend a lot of time on that because it's really key that we want to protect our own autonomy, that if I'm not able to speak for myself, I at least want a trusted loved one to be able to stand up and represent me as I would want. And lastly, what kind of a legacy do I want to leave? As we all go through different stages of life, we have different tasks. And, when you're in adolescence, you're trying to figure out, who am I? Young adulthood, you're trying to figure out the importance of relationship. And then in your working years, you've got your work and your career. In the later years, it's about legacy and generativity. What do I want to leave behind? So knowledge is love. Our care partners, if they know what to expect, can help navigate the future. And we know that being a caregiver is exhausting, and no one should do this alone. And so it's a chance for the caregiver to hook into supportive networks and care providers. And it's vitally important. I spend so much of my time with patients and families who are struggling with dementia, that the caregiver not become isolated, because you are that person's whole world in many ways, and then it can tax you in every way imaginable. So as we know what's going on, and as you've shared stories with your support network, you're more able to navigate some of the complex decisions that lie ahead. For those of you who have not heard of this book, it's one I very much recommend. And this is called Learning to Speak Alzheimer's by Joanne Koenig-Costi. Now, her story, she was a new mom, had about, I think a 2-year-old. And her husband, who was only in his early 40s, started to develop early onset Alzheimer's disease. And as she was managing both the toddler and the person with dementia, she was noticing how some techniques were really helpful. Techniques from raising her toddler were really helpful in working with her husband, who was suffering from dementia. And she coined the phrase the habilitation model. And what habilitation means is you're meeting the person with the skills celebrating the skills they still have, and not bringing them up against the skills that they have lost and will not regain. So, for example, doing a game requiring intense coloring or drawing when someone has visual spatial skills challenges, that's going to frustrate them. Or asking somebody to do a word game back and forth and remember, that's going to frustrate them. It could also just be that, I want to make a cup of tea, but I can't remember how to put the tea bag in the teacup. How do I do that? Maybe we come along and we already have that step there, and then a sign that says pour hot water into cup. There are so many ways that we can be creative, because on the other hand, if we bring someone up against a skill that's lost, so say, for example, visual spatial skills, and we've got really complex paint patterns all over our house, that can be very disorienting to the mind that's having trouble anchoring to reality. So we're going to talk a little bit about the roadmap here, where we make a dementia diagnosis. We talk about research participation, caregiving, and prevention. So this is a roadmap series if anyone hasn't seen it. Pearl number one, when you get the diagnosis of dementia in your loved one and you're hearing this floating out there, there's a saying in emergency situations, before you take the patient's pulse, check your own. And it's so important to check with yourself and to know that you have got time. And we'll talk about what are the areas that you may want to start thinking about in the care of your loved one who has dementia. So pearl number two is the 6 Ds. So the first one is domicile. I could have just said home, but then it wouldn't have been 6 Ds. It would have been 5 Ds and an H. But when we think about this, what's the plan for the home? Is this a home that's 1 floor living? Is it near healthcare services? Are family and friends nearby? Who's going to do the maintenance? Do I downsize? Are we looking at adaptive equipment? The other part of it is what's my community look like? What is my neighbor? You know, some people do very well staying in their own home with dementia because they have someone living with them. They've lived in that neighborhood for 75 years. They are connected to it. Taking them out wouldn't make sense. But how do we think about that? Do I want to age in place, or do I want to maybe go to a place that is more continuing care community where if I start to fail more, those supports are ready to go when I need them? And similarly, as my disease progresses, am I looking at maybe needing to go into a dementia care unit at an assisted living or at, in a long-term care facility? Which brings us to the next part, dollars. Most of us are not Rockefellers. A lot of stuff takes money and planning around money. So leaving a legacy of wealth to the next generation is often the goal of people. But we don't want that to be at the expense of someone's health care and living comfortably in their remaining years. So if you need, how are your finances? What do we need to do to be better positioned? And if I need help being cared for, or I'm a caregiver needing additional help, who can I turn to for assistance? How do I plan for being cared for? And then thinking about things like, how do I pay for my medications? There are some very expensive common medicines out there that, patients have to take. And sometimes it can be a choice of food or medicine. And if that's the case, there are people who can help with that. Thinking of your local aging services access point, or ASAP, which is often called your senior center, is one place to turn to for support. Now, I put drugs down, and by drugs, I meant medication drugs. I didn't mean, street drugs. So we can accumulate a laundry list of medications over the course of our lifetime. So my cardiologist gives me this, my endocrinologist gives me that, my neurologist gives me this, my primary care doctor gives me that. But what can happen is the more medications I'm on, the more likely that I may have a medication interaction, or that I just might not be able to keep track of them, especially if I have cognitive impairment. So there's often we're often wedded to certain medicines because we've always been on them. Well, I've always taken this medicine and I've always had my level at this. But at this stage of life and with dementia, We will sometimes reframe the importance of certain drugs that may no longer be serving the patient and just exposing them to adverse effects. We really like to streamline the medications for patients because, number one, no one likes to take a meal full of meds. And when you're on 20 medications, that's like taking a meal. And so you're not having your meat and veg, you're not having your whole healthy grain and your lean protein, you're not eating right. We want people to enjoy their food, get as much nutrient as they can from natural sources in their food, and then take the medications as necessary. Sometimes there are medicines that a patient is taking twice a day when there's a once a day formulation. Sometimes a person with dementia is at home by him or herself and doesn't remember to take medications. So how are we going to do a med reminder program? Sometimes we have machines that are alarms that will say, hey, take your medicine. Sometimes we'll have blister packs. It totally depends on how independent a person can be, and it will change over time. The next topic is a lecture in and of itself, and it is called driving. So this is definitely the hardest conversation we have in our clinic. Sorry, oopsie. Sorry. I'm just trying to scroll down here. Freedom and independence and driving are part of the American fabric. It's just, you know, we all couldn't wait to get our licenses. When we got our license, we were driving. It's the way we get around. A lot of communities are designed around the car. But if we're having trouble with driving in terms of getting lost or making poor judgment calls and having fender benders or accidents, or a police officer has noticed us more than once, or the family has expressed concern. No patient that I've had this conversation with who has dementia has ever said to me, sorry, let me reverse that. When I have tried to have a conversation with some patients who have dementia, they have said to me, I would never get behind the wheel of the car if I thought I was going to hurt anyone. And that sort of says it all right there, because we have objective testing, and this is not about objective testing being wrong. This is about, you might have good judgment at this moment, but you will not necessarily have good judgment at every moment. And we have the findings that prove that. So many times people will ask me, they'll say, Doc, you have to take away my dad's keys. You have to tell him he can't drive. And it's hard to be the heavy, whether you're the family member or whether you're the doctor. But the fact of the matter is that it is helpful to have a driving assessment by a trained occupational therapy team like they have at Spaulding. It is very helpful because it provides the patient and the family with the clear objective findings. Usually, if we're recommending that someone go for this test, we are expecting that they will not do well, but we have also had moments when we are pleasantly surprised. And no one wants to take away anyone's freedom and independence. And we sometimes have to do that in the name of safety. And what I will try to do in those conversations, and I say try because it doesn't always go over well, is I try separating out the driving from the independence. These days, we have rideshare apps like Uber and Lyft. Some patients with early dementia can train themselves to use this, and they get quite comfortable with it. There's also another service called Go Grandparents, which is an intermediary between the person and Uber or Lyft. You just call an 800 number and they say, hi, Matt, where are you going? And I say, I'm going to the doctor's office. And they say, okay, when is it? And I say, I'm going in about an hour. And they said, we'll have a car there 15 minutes from now. So you're good to go. These are ways that people can experience independence and self-determination and not be behind the wheel of a car. Other things that will happen is family members will say, I never let dad drive alone. I'm always in the car with him. That's not safe. If I said to you, would you let your grandson, your 4-year-old grandson ride alone in the car with grandpa? Absolutely not. There's your answer. And it's a very hard one, and it's heartbreaking because a lot of times people will attach it so much to their sense of independence, and we have to reframe. Decision-making. Who's going to decide what's right for me? Well, I am, for as long as I'm able to. And then what happens when I can't? So if something happens, I need to make sure that someone is designated to speak for me, yes. And I need to make sure that they will accurately represent my values and wishes and hopes for this stage of my life. Many times we pick our spouses, but we don't have the conversation with our spouse about what we think we would and would not want to endure. So for example, the classic one that many people will come up with is around resuscitation and intubation, meaning if my heart stops, do you try to restart it? If I can't breathe, do you put me on a ventilator and have a machine breathe for me? Many people are able to give those answers, but it's not that there's this telepathic link between you and your spouse. We've actually done the studies, and it's no better than chance unless you talk about it. And you talk about it with your healthcare proxy, the person who's going to speak for you, and you tell the peanut gallery, the other people who aren't the healthcare proxy, what your wishes are and why you've chosen this person. Because filling out that little piece of paper is only a little part of the story. You need to tell them what your hopes are. And many times people will sort of say to their loved one, I know I have dementia, but you have to promise never to put me in a nursing home. And there are so many times that I, as a doctor, have had to say to the caregiver, who says, I promised I would never put him in a nursing home. Well, you haven't slept in 6 days. He's fallen 4 times. You haven't been to the doctor. Your blood pressure is out of control. It's your safety at this point that I want to make sure we're taking care of, as well as your loved ones. And it is a hard decision, but at some point, especially if you're doing this all by yourself, it is hard to sustain. And so I always like to tell people, I will do my best to keep you out of any kind of facility for as long as I am able to care for you without ending up a patient myself. That is a reasonable thing to say. Now, invariably, we have decline. This is what dementia is. And so we will talk about what goes into our consideration for what I need to do now and what I want my care to look like. So, as with a lot of conversations about death and dying, most people, if polled, would say, I just want to be struck by lightning, take me away, and I'm gone. And that isn't the American experience of decline and death. We can be a little bit rosy-colored in thinking that, this person takes to their bed and then they're surrounded by family and everything is cozy and then they pass away in peace. But the reality, especially for people who don't have the ability to speak for themselves in advanced dementia, is that patients can find themselves on a medical conveyor belt, going from procedure to test to treatment, and then from hospital to home to rehab to home to hospital. Often, we on the medical side are slow to recognize that this is where a patient is at because, they have a pneumonia. I can fix the pneumonia. Yes, but they were recently admitted for heart failure, and then before that, they had a fall with a hip fracture, and before that, they had a whole bunch of other things. So this is a way of us realizing that the increased throughput through the health system, through health episodes, is actually a sign that a patient might be entering a different phase of life during which the usual stuff, the usual suspects that we do as traditional medicine may not actually serve the patient. But we're all doing the next thing we know to do. And you wonder, patients might wonder, and family members might wonder, is anyone looking at the big picture? And asking that can require a lot of courage. Not only do you want to be aware of what you want for the close of your life, but you want to have the ability for your family to ask those difficult questions. So finally, one thing about decline and death is that, especially with dementia, there's a social withdrawal. People will say, I can't be around my friends because I'm not as sharp as I used to be, or I don't want them to see me like this. And so while I'm not saying this is something we have to welcome in, strangers and acquaintances, the people who are closest to us often want to participate in our end of life closure. And we want to protect people from pain and sadness, but this is universal. This is a universal experience. And not talking about it and not sharing the walk can often compound the suffering. So one example that I will give you is we will often experience people having progressive disease, approaching end of life, when the people local who have been taking care of them have shielded the rest of the family from what's going on. And then when we call the rest of the family in, they had no idea. They had no idea it was this bad. And they may have been able to offer financial help, or they may have been able to offer, relief help or something like that. So we just always like to encourage. I call these people tongue in cheek, there's the local caregivers, the people that are there 24/7, but then there's the whole rest of this person's world that are the peanut gallery. And how are you keeping your peanut gallery protected so that they can actually participate and support the person you've selected to speak for you? So again, pearl number 3, don't do it alone. It's really hard to live this life alone under any circumstances. It's impossible to take care of a person with dementia by yourself. That help is so key. And whether there's actually easily available help from friends and family, or if you have to search through the more formal systems, get it, because you need a sounding board to help navigate this situation. For those of you who haven't seen our website, the Dementia Care Collaborative is here. The Alzheimer's Association, alts.org, is phenomenal. I draw many slides from their website when I'm giving talks. And then there's also the Family Caregiver Alliance. We do have research studies underway. So if you are a part of our practice and you are coming in to see one of our providers, certainly ask about if there's any availability to participate in research studies. No one is going to say that this isn't a devastating diagnosis, and we want to understand it better. And this is how we get to do it. So just to close out a little bit, let's talk about Sandy. So she was our retired school administrator. She admitted that COVID has been very hard for her and she was feeling down. Her blood work was done, which showed that some of her vitamin levels were low. Her cognitive screening test revealed only very mild cognitive impairment, and she screened positive for depression. So what we did for her, we started her on vitamins, so a vitamin B12 supplement. We started her on an antidepressant. The daughters created a family cooking day on Sunday at mom's house to make meals to eat for the rest of the week. So it sort of became like a Sunday working dinner. And after they're done cooking, they have a nice Sunday dinner. And the primary care doctor is going to follow the cognitive testing to see if things improve. And then Sandy's going to start exercise classes at the local senior center 3 times a week. Many of us suffered extreme isolation during COVID as senior centers and other outlets closed down, but they're open now. And it's important for us to remember that, the mind lives in the body and both need to be healthy. So now let's talk about Dave. So this is our retired bus driver. His physical exam and blood work were all fine. When we asked how he felt his memory was, he said, fantastic. So we did cognitive testing on him, and he struggled with many domains, including visual spatial, recall, word finding, thought abstraction, and basic orientation. He scored in the moderate dementia range. Brain imaging showed decrease in the total volume of his brain, mainly in the temporal and parietal lobes, findings classic for Alzheimer's disease. So we shared our diagnosis with the family, and we talked about them getting this book, Learning to Speak Alzheimer's. But Dave didn't really feel like he had any problems, and he had no insight into his deficits. So we often will forget this in caring for our loved ones with dementia. If the skill is lost, he's not going to reason well through this. So we're not ignoring Dave, we're just not challenging that skill that has been lost. So we decided not to keep sharing the information with him about his diagnosis. So fortunately, he and his wife had already completed a healthcare proxy and power of attorney paperwork. So the healthcare proxy form designates a healthcare agent for medical decision-making in the event that you are not able to speak for yourself. The power of attorney paperwork, designating a power of attorney, is a similar thing, but it relates to your finances and business things. So you should have named both. And it doesn't have to be the same person, but they should both be taken care of, because you don't want to be the healthcare proxy and not have the ear of the power of attorney when it comes to getting additional funds to make some additional care services in the home. So since he's historically social, we recommended he attended adult day health programming. So many senior centers have an adult day health, which is several hours a day, Monday through Friday. People with and without dementia can go there for socialization, for a hot meal, and there's a nurse on site, which can be very reassuring for family members, especially if the caregiver is, say, a working person who really can't be there 24/7. We discussed starting him on donepezil, which is also called Aricept, with the hope that it will help with some of his memory and behavior symptoms. And we also talked about revisiting it, the efficacy of the medicine, on an ongoing basis. We recommended he wear a wandering bracelet, giving an updated photo of Dave to the local police in the event of any wandering episodes. So there's a silver alert. You've heard of Amber Alert in Massachusetts. There's also a silver alert. So if you have a loved one who has dementia, you can reach out to their local police department and ask if they're participating in the silver alert for older people with dementia. All cities and towns are expected to have this, but they're still in implementation phase. I just looked online and I saw that Mashpee is active with one, but just make sure that there's an active picture, because time is of the essence. Certainly on a night like this, if somebody went wandering, we would want to have an updated picture, and we'd want to alert the authorities as soon as possible. So I'm just going to close and just say a few things, that pursuing the diagnosis of dementia is an act of empowerment as well as love, that this really gives you a chance to get a sense of, well, what is the trajectory going to look like for this particular person? What do I keep an eye out for? And how do we plan together? How do I ensure that my loved one with dementia is able to participate in this life as much as possible? And it takes multiple forms, planning. It's financial, it's medical, and it's also about just the literal bricks and mortar. Where is this all going to take place? And because it's so multifaceted, we really want people to join with the team to make sure they're getting the best advice possible. So I think I'm going to stop share now. I think that's all I have. I don't know, Chris, if you want to Oh, here we go. Great.
Yep. Well, thank you so much, Matt. That was wonderful. Before we get into Q&A, I would just like to remind everybody that if you have a question that you would like to ask Dr. Russell, to please type it into the chat box, and I will read it aloud, and so we can get through everybody, hopefully, before we adjourn for tonight. There are a couple of comments and a couple of questions that I can see already in the chat from two from Barbara. The first one is, in addition to depression, which Sandy had, are there any other conditions that are treatable and not dementia?
Yeah.
I think this is a common question I think we often get over in the memory disorders unit as well. In that, is there anything that can sometimes mimic dementia, but it's not?
Perfect question. So the short answer is yes, there are several things. That's why when we first are assessing a patient, we're checking sort of a slew of lab work, because things like electrolyte abnormalities, underactive or overactive thyroid, certainly depression, some vitamin deficiencies, these can look like a dementing illness, but are actually not. The three hobgoblins that exist in this space of mentation are dementia, depression, and delirium. So when someone is acutely ill, and dementia doesn't come on acutely, but when someone is acutely ill and they are older with multiple medical conditions, they can be acutely confused, disoriented, lethargic, not knowing what day it is or where they are. That's a person who is experiencing a sudden change in mental status. That person needs to be assessed for delirium, and that is generally an emergency situation. Dementia itself is a slow and progressive process. It can be because of any number of neurobiological pathology. It can certainly be associated with what people will sometimes call mini strokes or vascular dementia is one of the kinds. Sometimes something as simple as a medication can cause someone to appear off. So we'll see that in people who are using benzodiazepines, which is the APAMs, like Valium, Ativan, diazepam, lorazepam. Those medicines can cause people to seem off. I'm trying to think of some other medications. I'm blanking on them, but a thorough medication review is really essential to make sure we're not missing anything. And that includes over-the-counters, because over-the-counter medicines can cause interactions with prescription medicines, and we may not know you're taking the over-the-counter because that's not in our prescribed list. So being very clear with everything that you're taking, including herbal supplements, vitamins, proprietary blends, etc.
Right, thank you. So the next question is, how do I decide who to inform about my relative's dementia or dementia in general? How do we decide between family, friends, neighbors, etc.? Any advice?
Yes. So it is very important to recognize what the person's pre-morbid privacy level is, privacy settings. Like, if you were a kind of person who would never share your medical story with anyone, would we do it now? Only if necessary for the safety of the person. In terms of asking the person with dementia, I always start there and like, what would you want people to know if you're able to have that conversation? If you're past that conversation, then, and you're the healthcare proxy, then it might be a more nuanced consideration of why am I sharing this information? So if a family member is calling from afar and they're having a frustrating conversation on the phone, it may be helpful to share ahead of time, hey, listen, so-and-so is having some memory things. So my recommendation is keep your questions, don't ask about current events. Remember good old times, because those memories tend to last longer. And don't challenge people with strong emotion that could become very distressing. In terms of telling friends and neighbors, the phrase "it takes a village" is floating through my mind. But if there's someone wandering I would want them to be seen by a neighbor who knows this ain't right. And that is something that, you want it to be a trusting neighborly relationship or a trusting friend relationship. You don't want this person to be exploited by someone, and that's just down to judge of character. I don't speak to that, but it can be very helpful, because if a neighbor knows, I'm taking care of my dad, I'm doing this constantly, I need a break, can I call you to come over and sit with him just so I can go out for a half an hour to get a cup of coffee? It can make all the difference in the world for that caregiver. And when we think about what's called the nidus of suffering, where does the suffering live with dementia? When I'm first diagnosed, I'm grieving the loss of my memory, the loss of my brain skills. I'm very much suffering. But as the disease progresses, I become less aware of that. And my caregiver becomes the locus of suffering. And so I, as a healthcare provider, I'm taking care of both, because I need that healthcare, that caregiver to be healthy and strong to be able to continue their work. And I recognize that they need the break. So I will often say, yes, share that in a way that is respectful and protective of their dignity. Many times when people with dementia have distressing behaviors, like they become hypersexual, or they start using vulgar language, those are times when where I put my loved one is going to matter. My loved one would be mortified if he knew that he was doing this before as the person before he had dementia. So I'm not going to let him be seen doing these things, so that I can keep him his dignity as I think he perceived it intact.
Great. Carolyn asks, how do you approach a loved one with signs of early dementia about going to a PCP visit with them for cognitive assessment? What are the best words to you? Is there any advice or any wisdom you might have?
Yes. It's not easy. Many of the calls I get from friends are about exactly this. There's something wrong. Dad won't go to the doctor. So what do we say? It's a new phase and a new stage of life in a lot of ways. And so what I recommend is going the comprehensive geriatric assessment route. So for example, in our clinic, if somebody comes, we're checking their physical health, their cognitive health, reviewing their medications, and going over their planning around things like designating a healthcare proxy. So we'll detect that cognition issue, and we'll form a partnership with the patient, the caregiver, and our team to work with that person. But when someone doesn't have insight because of dementia, you are literally screaming against the wind, because it's not going to be received in a way that you're hoping. What I will tell people is, we're going to go to the geriatrician for a tuning and checking. You can call the primary care doctor and ask them to perform a MOCA, which is a Montreal Cognitive Assessment Scale screening tool to look for cognitive impairment. But you can call them ahead of time, and you can ask the primary care doctor, could you also refer to a geriatrics group, so that we can get further assessments done. But it ain't easy. And I will sometimes focus on, I want to make sure, you're up and running now. I want to keep you running. I want to keep everything going. Sometimes I'll say is it takes a lot of work to keep a classic on the road. So let's get you in and tuned and checked. I use the auto metaphor.
Awesome. Thank you. Ellen asks, after the diagnosis, how do you deal with the natural reaction of family members mentioning things they notice, and the patient feeling like they are under a microscope? I actually might have some thoughts on this as well, given the work that we do, but
Yeah, go
Matt,
ahead.
any thoughts?
Go ahead.
Well, I would say this is a very nuanced issue that we face day in, day out. Usually, I talk with families about, and it very much depends in terms of where the patient's at in the disease process, whether we're talking early stage, moderate stage, late stage. But it all comes down to, number one, respecting, autonomy, and a lot of times simply asking if it would be okay to talk with family members one-on-one is the only thing that needs to happen in order to have a nuanced conversation. I try to do that whenever we can, because sometimes, again, due to memory loss, there are times when, talking about symptoms or what people are noticing in front of the person can be just all it's doing is just upsetting the person. We're calling attention to symptoms, we're calling attention to deficits that the person may not be aware or cognizant of. And who's to say that, 30 minutes, however much time passes after that conversation, will they retain that information? Basically, what I'm saying is, like, does the person need to be, part of this conversation if it's only going to upset them in the moment? And so, again, it's a very nuanced, type of scenario. But bottom line is that, we make we make judgment calls in terms of, a patient's support system, their family, whoever is around them. We establish trust with people, to speak on our own behalf. Again, pointing back to the importance of, planning for the future and and identifying people who to make decisions for us. We place trust in these people for a reason. And so, we try to make this as easy for both the caregiver and the patient as possible. And sometimes that involves just separating the conversation.
I know that natural instinct of wanting to wrap our loved ones up in bubble wrap and protect them can often be suffocating. And the illusion of safety that we get by sort of hovering and all that is balanced with what's called the dignity of risk. And so walking that very I would have said the new word, Chris would have said the word nuanced, but it just is the word for it. It is something that you really have to navigate well with the patient and family, because there is no clear one solution fits for all.
Right.
I see there's a comment about specific nutrition, exercise, and activities, and does a routine help?
Yes.
So yes to all of that. Certainly a recognizable routine, anything that provides external scaffolding to reality is vital. So same time sleep, same time wake, same time eat, breakfast, lunch, and dinner. Activities and exercise matter. You can certainly have the treats, but when somebody is struggling to anchor to reality and something varies, like even taking someone, like we took mom down, from her home down to our house on the Cape for the weekend, and all hell broke loose because she didn't know where the bathroom was and she was confused and agitated. There may be considerations around things like where we celebrate the holidays and how we celebrate the holidays. So we bring the party to mom, and we're there for a shorter period of time to be able to have her celebrate and not be overwhelmed by this and not to interfere with her sleep schedule. Exercise, yes, 150 hours a week for anyone age 65 and over, as much as you're able to. What exercise looks like with dementia depends on what stage you're at. If you're in the earlier stages and you can do things like Tai Chi or resistance exercises, great. If you're a little later on, maybe you can do gardening, maybe you can do light housework, something that keeps you moving. Dietary wise, we certainly, especially in people who are living alone with dementia or, someone isn't with them 24/7, nutritional deficiencies really can complicate things. People are not making meals for themselves because the coordination of steps is a little too hard. And so they say, okay, I'm just going to make myself toast. And then the toast doesn't have great nutrition by itself. So we recommend a diet rich in lean proteins, fresh fruits and vegetables, and whole grains. That's never going to be a wrong answer, but how we get that is going to be very important. How you get that buy-in from the patient, whether it's a meal delivery service, or if they're able to follow limited instructions, or if it's just reheating, as we did with Sandy's group, Sandy's family, they made the nutritious meals and all she had to do was reheat them. That's what we do in my family. We have a big Sunday dinner, and then we leave the leftovers at my mom's house, and I hear by Thursday, all right, they're all gone. What are we having this weekend? She's fine in cooking, but it's just nice to do that. You mentioned grief during your presentation. In addition to the losses that the person with dementia experiences, can you speak to the grief that caregivers feel even when the relative is still alive? Yeah. So I think both Chris and I can speak to that.
Yeah, I tend to throw around two alternate terms for this particular concept. One is complex grief, and the other is more a term that I use commonly is called anticipatory grief. Both relate to essentially the loss of a person's functions, a person's memory, a person's faculties, things that contribute. They don't totally define, but they contribute to how we interact on a day to with the world around us, and to some degree make up who we are. And so while the person is still physically with us, I think that with any grieving process, it's exactly that. It's a process. And I don't think people tend to really think that they're grieving until you point out, these types of things. And all of a sudden, people are, you see the same type of stages with grief is, you have negotiation, you have anger, you have, acceptance, and all the other stages associated with that. And, it comes down to the fact that, we're suffering loss while the person is still with us and still, part of the physical world. So one question I had for you, Matt, just as we're talking, because I think we talked a lot about the importance of getting in to be seen, to be evaluated, and getting a diagnosis. In your practice, or from the perspective of a geriatrician or a primary care provider, are there any particular sort of warning signs or risk factors that you come across as being particularly important to consider before recommending somebody go for a memory evaluation? Is there anything that sticks out to you?
Not sure I understand. Let me see if I can get this.
Well, I guess another way to maybe phrase it is, in your experience, what would you say are the most common things you see to point that to the importance of maybe this person should go for a further evaluation?
Gotcha. So thank you. It's a great question. So one, the hospitalization experience. Something happened at home where it comes to pass that things aren't right at home. So this could be a fall. This could be some kind of event that happens that results in a patient being hospitalized. And then we see the patient in the hospital, we do the screening, and the family says, I had no idea it was this bad. I walked into the house and there was, the trash had piled up. They hadn't taken it out. So that can be the more extreme version. The other thing that can happen is the neighbors have noticed things. He's starting to be more combative in relationships. He stopped talking to my mother. Any number of things where there's just sort of a behavior change that's out of character for the person. It's not uncommon that we hear banks and credit card companies calling family members or trying to track down family members when they see things like triple payments of bills or no payment of bills, missed mortgage payments, things like that. So when we have things kind of going awry, certainly with the driving, anytime if a police officer says this person shouldn't be driving, and there was one more that I forget that I was about to say. Oh yes, when accusatory behavior starts to come up, meaning why did you take that? Why did you move that when it's in the other room or the person misplaced it? That can be something that when you live with the person, that can be a sign that says what's going on. People will sometimes have sleep disturbances that they never had before, trouble initiating sleep or abnormal movements during sleep that can impact the other person sharing the bed. those are some things that come to mind. It's certainly, when I think about the finances and the safety. Those are the things that really make me wonder if something is going on.
Thank you.
I did have to clarify something because Maddie asked to elaborate the phrase dignity of risk.
Mm-hmm.
So I'll give the classic experience. Mom and dad live together down in Baltimore. I live up here in Boston. Dad dies. I'm going to move mom up from Baltimore to live in an assisted living up here in Massachusetts. As someone in his 50s, that might be a reasonable step to take. But as the person who's in their 80s, who is linked to the land down in Baltimore, who has a very, very vigorous and deep connection to their local church and neighbors, all of that kind of stuff. Well, I don't want mom to be alone because I don't want anything bad to happen to her. So it's that wanting to keep mom safe by bringing her up to this assisted living where she has no connection maybe, and she's going to miss her friends. I'm giving this illusion of safety as opposed to just letting her have the dignity of risk of she can just live her life down there. And when the emergency happens, we'll have systems in place so that I will be notified as soon as possible. So that's kind of what I was saying, that we're often hearing family members out of a place of love wanting to keep their loved ones safe. And our patients will say, thank you, but I'm not going to go all out there. People will sometimes say, if they have falls, wearing the life alert. People will say, I'm not wearing that. I don't want to feel like I'm tagged like a bird for migratory purposes. I don't want that. And, while we'll recommend that and family members want that, you can understand where the person is coming from. And so listening to that expression from the patient is key.
Yeah, I think another way to sort of consider it as well, at least if I understand correctly, balancing autonomy versus, the safety concerns that present themselves over time.
Correct. Yeah.
There's a phrase that I use, especially when I'm talking with family members and they're concerned about a particular, living situation, or thing that a person does, is that in some cases, a person may do something that we don't necessarily agree with. We might have, rationales and sense on our side in terms of like, it would be so much better if this person, just moved to an assisted living facility. They would have all their care in one place. It would be so much safer. But we have to recognize that, autonomy is still paramount to the degree that it can be, respected. And, people still have the right to make decisions that we don't agree with. And it's a very delicate balancing act. And it's something that, we constantly, reevaluate and reassess. And it's tough. It really is. Let me see. Do you encourage patients to make connections with others living with cognitive changes, others who can give them tips on living well?
Yeah, I think in general, I'm a fan of everybody's welcome at the table. I think human connection and interaction is probably neuroprotective. It is neuroprotective. I don't think it is neuroprotective, meaning if we are not in connection with other humans, we atrophy. And we certainly saw that during COVID when people were isolated for the first time in their lives. We saw an enormous increase in cognitive impairment because of that. So it can be very helpful to be around your peers. I will just say, the logistics of people with dementia, if they have behavioral disorders or if they are on different wavelengths, it is something that interaction would need to be curated or facilitated by someone like in an adult day health program. But certainly getting people out there, getting them social, it is we all want to delight in life. Now, if you were an introvert your whole life and you were never really a people person, I don't expect that people suddenly become people.
Yeah, particularly in that case, there are times when, that can sort of be counterproductive, just because, we know that, social connections can be beneficial. Doesn't
Mhm.
mean that person for person that, we have to shoehorn that in for everybody.
Right.
It's, we do what we can with what we have. And if we can facilitate social connections, great.
Yep.
Um, but we don't try to push, because that can lead to unintended consequences as well. Carolyn asks, what are the best words to use to implement safety modifications in the home of a fiercely independent person with cognitive impairment? For example, when we're installing hand railings, anti-skid strips, environmental safety adjustments.
Yeah, I mean, again, to your point, this is really, are they going to remember it in 30 minutes? And it depends on how advanced the dementia is. But what I will typically focus on is, I may not want to admit dementia, but I will certainly admit I don't want to fall and end up in a dependent state. And so I will often say to people, it's because you're so functional. It's because you're so independent. And I don't mean wink, wink, nod, nod, but I want you to be able to do this, and just give it a try. Just give it a try and see what you think of it. It's really, really helpful to partner with a patient on their terms in a way that they'll be able to incorporate that.
Right. I will also say that, generally speaking, patients with dementia, change is hard. And, and as we get older, sometimes it can be the case where, we become more and more resistant to changes in our environment. And that becomes more the case, I think, with patients with dementia, particularly because of the orientation issues, adjusting to the new things in our environment can be difficult. So to your point, Matt, sort of meeting the person where they're at and sort of taking what they give you, maybe some adjustments in the home start small, maybe not remodel the entire house from top to bottom, maybe start with a few, what I call high risk areas, things like the bathroom, egresses, front door, back door, kitchen, start small and work your way out. Because sometimes that can lead to better, to more acceptance, or at least, not as much resistance in those areas. There will be times when you're not going to be able to convince the person that, these changes are necessary. That is reasonable to expect. But, again, it's about balancing that autonomy versus safety. If the safety concerns are outweighing the person's want to be autonomous in certain areas, then, we sort of have our answer in those cases. So, but it's still challenging however way you slice it, but starting small and working way up, I think, is usually a good way to go. Let me see. Geriatric medicine consists of many professionals. Can you comment on what constitutes a typical interdisciplinary team?
Oh, this is a great question. Oh, you don't know what you've done by asking me this. So the first order of business of geriatrics is to recognize it ain't the doctor. So like, I'm the medical part of the slice of the pie, and I may be the first person that the patient comes into contact with, but my job is to build the team. Now, does every geriatrics patient need a doctor, a nurse manager, a social worker, a psychiatrist, a psychologist, a home health aide? No. But those are like the sample things. I mean, those are the sample professions that we'll use. In my clinic here, every patient is assigned a doctor and a nurse practitioner. Well, why are they assigned to providers? Because I don't want to miss anything, and having a practice partner is the way to do it. And we trade off on visits so that we're both looking and checking each other's work. That's what you want, because this is a complex model. Again, this is about keeping the classic on the road, and you want to make sure you're keeping track of what could be going wrong. It's very often that we will have to involve our triage nurses, our case managers, and our social workers when things become more complicated. But team isn't just like us in the office. It's the family. The patient is obviously the head of the team. And and sometimes my job is to just name that. And this might be a medically complex person who's seeing a bunch of different specialists. And we say, guys, you're all prescribing every drug every which way, but Sunday, I need a pharmacist to be the gatekeeper to make sure that we're appropriately prescribing and that one hand isn't doing something that'll counteract what the other hand is doing. So the team structure is really depending on what's going on. We think of, in geriatrics, we think of the 4 M's. So we think of mind, medication, mobility, and matters most. So when someone's on a ton of medicines, maybe pharmacy takes the lead. Where someone's having mobility challenges, maybe the physical therapist takes the lead. Or if someone's having, nutritional issues, maybe the dietitian takes the lead. It's an interprofessional for a reason, recognizing that we're all on the team and someone is taking lead.
Great. Thank you. I will also say that, a big part of the work that we do is making sure that, as much as we can, because people can have a lot of different providers, psychiatrists, geriatricians, specialists of all kinds, making sure that people aren't operating in silos is a big part of our work, and making sure that, we connect teams and facilitate communication is critical for just that very reason, even if it's just to do, a medication review to make sure that everything is on the up and up. Another question here, the focus seems today to be more on later stages. We encourage early diagnosis so people can have many productive years living their best lives. Do you have recommendations for the very early stage or MCI patients?
Oh, this is great. Yeah, so the recommendations will not change. There's more, but the things that we talked about, making sure your ducks are in a row and planning and thinking about what you want the phase of your life to look like so that you're in a safe setting, that is safe for you, that's important. Certainly, we know from the research that regular exercise, 150 hours a week, actually can help prevent progression to dementia. So MCI, helping this manage. The diet, not drinking, not taking sleep aids, having a thorough medication review. So when I say not sleep aids, I don't mean melatonin. I mean drugs like Ativan, Xanax, benzodiazepines, and again, just some over-the-counters. Sometimes people will take something like Tylenol PM, thinking it's just Tylenol, it's harmless, but in point of fact, it's got Benadryl in it. And Benadryl is a no-no as we get older because it can cause confusion, mental fog, urinary retention, constipation, and falls. Bone health is important because what you don't want to become, we all can become, but we want to take, we want to prepare as much as we can realistically prepare. But I want to make sure that my bones are healthy so that if I fall, I bounce, I don't break. And so I want to make sure that I'm up to date in my bone density. I want to make sure that I've got enough calcium and vitamin D to keep me going. And things like keeping my mind active. So, physical exercise is important. Proper nutrition is hugely important. Avoiding toxic substances is very important. But I need to be social, because when you're social, you're using your nonverbals a lot. You're reading a room. You're you're just engaging with people. And joining things like book clubs or movie clubs, if you're able to do it, and if it's your interest, do it. Sometimes people, I was at my mother's senior center, she's taking ukulele lessons. And my mother has never played an instrument before. And she says, I'm terrible at it. But it's just something fun to do to stretch the brain. And that is very important for us because neuroplasticity exists. We can, we talk about that. You can't teach an old dog new tricks. Yeah, you can. And so it is very helpful. Have intergenerational relationships. Get the grandkids or the grandnieces and nephews to show you how to use Uber and Lyft, even if you never intend to use it. Because it's a chance to hear something, to interact with someone from a younger generation, and to be present in a task together. One of the things that's really not great and helpful, and I'm guilty of this, is sitting in front of the boob tube. If we just go in and wake up in the morning, not separating much between our sleeping time and our waking life, other than I'm on the couch or the bed, that isn't gonna help with cognitive issues. Having a nice structure to your day where you're out doing something, whether it's a senior center, an activity, or even just scheduled phone calls with friends, volunteering, being on boards, anything that keeps you active will be helpful. I generally say I would never want to be put in charge of the books, even on a good day if it was me. And I think that if you're worried you might have mild cognitive impairment, I'd steer clear of having to be in a financial responsibility picture, or to plan for it at least. But I hope those are some good leads, because it is definitely a use it or lose it phenomenon. And whatever engages you will protect you.
Yeah. I will also say, in terms of just like, things to consider, upon diagnosis, referring to trials. I mean, research trials, I think, is a personal decision for everybody to make, although information and supports are certainly out there. So that is absolutely an option. Referral to helpful educational support groups. This sort of goes back with, a lot of the work that we do, is that, one of the things that could be extremely helpful is, number one, having a conversation, with, the family, at large about, just potentially disclosing a diagnosis, with the intent of being able to offer supports and educational resources to not only the patient, but the family. Eliminating any source of miscommunication or misunderstanding, regarding symptoms, I think is criminally understated in terms of its importance. To be able to interpret changes as not a product of the person, but as a condition or disease, is so important, because it allows us to restructure our own expectations, and to really put things within their proper, focus. And, a lot of the work that we do is offering those supports and those educational resources whenever we can. Although social connection is so important, what about seniors going to places like community centers while COVID is still with us?
An important consideration, and I'm never going to minimize it. I think it's important to understand that COVID now versus COVID in 2020, we manage it in a way that we feel much more comfortable. We've had 3 years to get a sense of how to manage it. We've also got, most of us have 5 vaccines under our belt. So we might be getting it, but we're not going to the hospital and we're not dying from it. So I think that one is checking what is the actual risk of harm to me if I get it. And the second thing is, what's the prevalence of COVID? So right now, I checked the wastewater thing, because that's as reasonable. We're not in a particular high spike of it. And you will always have the option at senior centers to wear a mask and to socially distance. And as with this is like the classic dignity of risk versus the illusion of safety. I'll stay at home in my bubble and I won't get COVID, but I'll become frail. I'll become a couch potato, and I won't have any social skills, like happened to me when I had people over for dinner. And I'm like, I forgot how to do dinner party. Get out of my house, you've eaten. But it is very, I think it's something that you want to consider. One, what is the actual risk of harm to me? Certainly if I'm immunosuppressed, if I'm on medicines that keep my immune system down, I'd be extra careful. And if it looks like this is going to be a very crowded experience inside. I never liked crowds, and I think this is one of the reasons why, but you don't have to do it. I wouldn't divorce yourself totally from the option.
Chris, I think a little farther back, there's a question from EM.
Let's see.
Did you see it?
From Eva Jean.
Mm-hmm.
What do you advise for people who have every symptom? Or if I might interpret correctly.
Oh, actually, I'm sorry. Farther down than that, they had a new question. That one didn't finish.
I think it says delete my prior message. It is incomplete for a tech.
Yeah, now the next one,
Okay.
I have another question. You want me to read it?
Yes.
Let's see. Hold on. We're getting there. Thanks. Perhaps another question would be, what provision does MGH provide for individual consults? And how is that arranged and how is it paid for?
Excellent. So if you were talking about through the geriatrics clinic, we have Barbara and Chris are on there are Dementia Caregiver Collaborative folks. One of our doctors, Dr. Hanley, is actually running a cognitive assessment clinic here in the geriatric section. All of us geriatricians do comprehensive geriatrics assessments, and they are paid and reimbursed by your insurance company, both Medicare and private insurances. All that's required is a physician order, and then you just can call our office, which is 617-726-4600. I'll just put it in there. If you want to make an appointment. And we're trying to focus our cognitive assessments with Barbara Moskowitz and Catherine Hanley, because they're actually the team that's forming this. And like I say, we're all adept at doing this, but this is really where we're wanting to focus these assessments.
And I will also say that if your loved one is a patient in the memory disorders unit here at Mass General, it's as simple as talking with your assigned neurologist about a referral over to us. And so, basically it goes back to talk with your provider and, ask to, see whether or not a referral to us is possible. We're happy to take on anyone that we can possibly help. So thanks for the point we're trying. So yes, so the cognitive health and integrated memory evaluation, that's what CHIME stands for.
Oh, thank you. I couldn't remember, so I said cognitive. Thank you, Catherine.
Absolutely. I will also just want to point out too, again, I go back to the work that I do on a daily basis, in regards to early stage or people who are just getting newly diagnosed. When I have discussions with folks in that sort of scenario, one of the main points I'd like to emphasize, and this might be a little bit oversimplistic, but it boils down to receiving a diagnosis of dementia doesn't mean that life stops. Is it something that is life altering? Yes. Is it something that we want to plan for and is significant? Absolutely. But it doesn't preclude, patients, and families from being able to live life in a way that is meaningful and positive. There are still things that we can take into account and still things that we can appreciate. And a lot of the work that we do is not only how do we plan for the future, but also, how do we identify, the little things on a day-to-day basis that keep us going. And so it's helpful to keep that in mind because, this is tough, however way you slice it, both as a patient and as a caregiver. But, the more that we can do to highlight, those aspects of, daily care, I think the better. All right. And with that, we are right at 7 o'clock. So right on time. So Matt, I just want to thank you so much for coming and talking with us today. I think that everything that we discussed and everything you presented was supremely helpful. So thank you so much.